Welcome to this video tutorial on PICC line access. PICC lines are peripherally inserted central catheters or non-tunneled catheters. That means there's a greater chance of them becoming dislodged or migrating. Also, they're associated with higher rates of infection, although they can stay in for days, weeks, months, or even a year. Most of the time, you'll find these in the upper arm or in the antecubital fossa. That's right, PICC lines do have a tendency to migrate. The distal tip of a PICC line is positioned in the vena cava just above the right atrium. Since PICC lines are inserted peripherally through either the brachial or basilic arteries, if a patient abducts their arm, they can actually move the tip of the PICC line into the right atrium and cause atrial fibrillation. Where do you think this PICC line is? If you guessed AV node, you're correct. This patient was in rapid AFib. You can easily see from this image that if the PICC line migrates in either direction a few centimeters, the risk to patient safety can be significant if it goes unrecognized. If the PICC line comes out a little bit, the distal tip can end up in the internal jugular vein. There are reports of patients hearing swishing sounds when they're getting infusions. If you get a patient with a PICC line and they have those same symptoms, I would avoid using it. Someone has a PICC and they really want you to access it. They're having no parts of peripheral venous access. And although it would be so much easier just to pop a peripheral line in, these are the patients that the policy for EVAD access absolutely applies to. Well, the first thing you really have to do is determine if the device is even viable. Then you have to get the patient's permission. And then finally, contact medical command. Provide all the pertinent findings, including pertinent negatives, and receive orders to access the PICC. This PICC line looks pretty good. The tubing looks nice and clear. There's no redness. It doesn't feel hot. There doesn't seem to be any swelling. It looks like it's been well maintained.
You're right, son. It was just flushed yesterday.
So you want us to access your PICC line if we need to give you medicine?
I would have it no other way, son. No other way.
Now this line doesn't look so good. All that blood left in the line is probably your first clue that it hasn't been really well maintained. And unless the patient is in cardiac arrest or nearly in cardiac arrest, you should probably avoid using it. The Save That Line acronym from the Association for Vascular Access will just help you to remember some important and key principles whenever you're accessing an established vascular access device. The S in Save That Line stands for scrupulous or strict hand hygiene. Strict hand hygiene is the foundation of all infection control. So let's say you're performing an assessment on a patient, and then later you decide to access their VAD. Take your old gloves off, clean your hands with an alcohol preparation, then put fresh clean gloves on before you go and access their VAD. There are two major risks to patient safety for patients that have an established vascular access device in place. The first is preventing infection. That means strict hand hygiene and making sure to perform strict aseptic technique. The second is preventing air emboli, and that's just a matter of performing good basics and taking your time when it's required. Continuing with my assessment of the line, obviously this line has two ports. They both say 18 gauge on them, and I know they're both headed to the same place, the superior vena cava. So to help make the decision a little bit easier, I'm just going to ask my patient. If my patient can't tell me, I'm going to access the lumen that appears cleaner. In this case, it's the red one. Another great resource for questions about the line might be the family members. A clean alcohol prep should be used each and every time you make or break a connection. Scrub all caps and hubs for 15 seconds with vigorous friction. Also, when you use a new alcohol prep, use a new syringe too. And remember, nothing smaller than a 10 cc. Research has shown that smaller syringes generate higher pressures and can damage the catheter. If a catheter is equipped with a clamp, always leave it closed before you attach and make sure it's closed when you detach. By remembering to close the valves or clamps, you add another layer of protection against air emboli. Blood can be withdrawn from PICC lines to ensure patency and for laboratory testing. There are some important steps that you must take in order to perform this safely. To safely ensure the patency of a PICC line, always use at least a 10 milliliter syringe. Research has shown that smaller syringes use higher pressures and could damage the catheter. By all means, take your time and withdraw the plunger slowly. Finally, use the push-stop method to flush and clear the catheter. Some manufacturers print the milliliter per second flush rate right on the catheter. However, some don't. So the safe guideline is to push 1 milliliter per second, then pause for a second, and then resume 1 milliliter per second and pause until you flush the catheter with about 10 milliliters of saline. Unfortunately, it's not uncommon for a catheter to develop partial occlusion such as a fibrin tail like the one shown here. The symptoms of a partial occlusion are poor or no blood return and difficulty or poor flow when flushing. If you encounter this in the field, it's best not to use the catheter, unless the patient is in extremis and there's no other access available.